right. Hi, everybody. So I think we're going to get started. So my name is Megan Parker. I am the chair of the Adult Cystic Fibrosis Advisory Committee with Cystic Fibrosis Canada. So on behalf of the Adult Committee, I would like to welcome you all to the second of an 8-part series on fertility and family planning for people with cystic fibrosis. So the Adult Cystic Fibrosis Advisory Committee is a standing committee of Cystic Fibrosis Canada. The committee provides perspective and advice on CF-related issues and advocates for public policies and programs for cystic fibrosis. Members also foster and support an engaged and knowledgeable CF community. So among the committee's various initiatives, we are pleased to host this webinar series through which different aspects of fertility and family planning will be discussed by a variety of expert guest speakers, as well as people living with CF that are willing to share their personal experiences. Please note that this is an educational webinar series, so we at CF Canada cannot provide any medical advice. Although the series will feature a few CF clinicians and other health professionals, we highly recommend that all persons with CF seek guidance from their CF clinic care team regarding their personal family planning process. So today, we are honored to be joined by Dr. Schramm. Dr. Carrie Schramm from Queen's University School of Medicine in 2008 and completed her residency in family medicine at the University of Toronto. Her passion for women's health led her to pursue a Women's Health Fellowship, and she has since achieved a Master's of Public Health through the Dalla Lana School of Public Health at the University of Toronto. Presently, she is an active academic family physician at Women's College Hospital, an assistant professor at the University of Toronto, and medical director of the Hannam Fertility Center Well Persons and Cycle Monitoring Programs. She conducted research on ovarian function and cystic fibrosis with support from a Canadian Cystic Fibrosis Foundation grant, which was published in 2015. So the Adult Cystic Fibrosis Advisory Committee is pleased to have her speak on our second topic of the series, Fertility Treatment Options, Part 1. So Dr. Schramm, I will pass it over to you.
Okay, thank you. That was a wonderful introduction. Just give me 1 second here to get my my slides up. Okay, so I really do appreciate that wonderful introduction. Just to let you know who I am, so I'm a family doctor, I've done a fellowship, and I've been interested in cystic fibrosis for several reasons, including a close friend of ours who has a son who has cystic fibrosis. And I really feel like I've been privileged to care for patients with cystic fibrosis, both in my family practice as well as in my fertility work. So as Megan mentioned, this talk is going to touch on a few fertility topics, which I think will be relevant to people. We're going to look at it as a referral process, common fertility tests for men and women, common procedures which can happen in a fertility center, emotional support, and we are going to save some time as well for questions. So the referral process. So what we know already, and I know that Dr. Tullis has covered some of this, but for those who haven't had a chance to see her talk as well, we know that about 97 to 98% of men with cystic fibrosis have absence of the vas deferens, that's CBAVD, and that the CFTR is located throughout the reproductive tract of women. So women with CF don't have something quite as straightforward as absence of a vas deferens. They often have thick cervical mucus, which can result in impaired sperm transport. And they may have a degree of ovulation dysfunction and reduced ovarian reserve. So the research I did looked at an ovarian reserve test on women with cystic fibrosis, and it found that the ovarian reserve in women with cystic fibrosis is less than that of women who do not have cystic fibrosis, even when we control for other variables, which was interesting and may actually shift referral timelines or what women should be thinking of when they're planning their families. So in general, in family medicine, what we're taught when we're doing our residency is we're taught to wait a year to refer people who are under 35 years of age for fertility treatment and 6 months if they are over the age of 35. And it's not because we think women over 35 will get pregnant faster, but it's because if they're having trouble, time is a little more of the essence, and we want to get diagnosis and treatment going sooner because age is directly related to the chances of getting pregnant. For men who have cystic fibrosis, there's no reason at all to not check a semen analysis and get referred early. We know that the majority of men will not have a vas deferens, which means that that tube which has to connect the testicles to the penis for ejaculation, that tube to transport sperm is missing. So the sperm cannot physically get out and cause a pregnancy. So there's no reason for men not to get tested to see if they are producing sperm or not, or if they're ejaculating sperm or not. They'll be producing it either way, but they may not be. It may not be coming out. And for women, I say it depends because we know that for women with cystic fibrosis, they might get pregnant quickly. It might take time, but if they have a low ovarian reserve, then time really is more of the essence because fertility treatment success is very closely dependent on the ovarian reserve women have. So what I say is that if women have cycle irregularity, then it makes complete sense to get a referral before trying or within 3 months, just for diagnosis and planning. It could be some very easy things which can help get their cycles more regular and help pregnancy occur. If women have regular cycles, they could try for 3 to 6 months. But again, there's no reason to delay referral, especially if it's a time when health is optimized and it's a good time for a couple to achieve pregnancy for a variety of reasons. So if it's a time when lung function is optimized and things really do seem favorable, there's no reason to wait 6 months or a year when perhaps things could change and the timing would be trickier. So for both men and women, in fertility clinics, we will do basic testing. This includes infectious disease screening, so everyone who's coming through. For men, it's much more straightforward. We want to know if they are ejaculating sperm, so we will do a semen analysis and we'll check their hormonal profile. For women, because women don't only have to produce a pregnancy but carry a pregnancy, we check their ovarian reserve, but also look at the anatomy of the uterus, their tubes, and we often monitor a cycle. Men have about the same hormonal levels all the time, but because women go through menstrual cycles, their hormones change from the beginning to the middle to the end of their cycle. So we do monitor them several times, and I'll explain this all in more detail. For a test for women, one of the primary things we do is a pelvic ultrasound, and that's to take a look at the uterus and tubes, as well as take a look at the ovaries. When we're looking at your ovaries, what we're doing is an antral follicle count. And ultrasounds are shades of gray, but you can see there's a lovely convenient arrow on this picture, which is pointing to an antral follicle. So that's a resting follicle. Within the ovaries, at any given time, women have a few to 20 resting follicles, and those are what contain an egg, which gets released at the time of ovulation. Antral follicle count is one of the tests we have for ovarian reserve, although it's less sensitive than a different test called AMH. So this is a graph kind of talking about AMH. So AMH is anti-Mullerian hormone. It's a hormone that's produced in the ovaries by resting follicles. AMH peaks at about age 24 and decreases as we get to menopause. What this graph is highlighting is that for somebody who has a regular cycle and isn't smoking, that around age 25, they're going to have an AMH in the mid-30s, and then it's going to slowly decrease over time. This graph was adapted and used for something else, so it looks at the effects of smoking as well as birth control pill use. When you're smoking, you are affecting your ovarian reserve, which I don't think we're too worried about with most people with cystic fibrosis. But I do want to highlight the birth control pill use, that's OC, oral contraceptive. With oral contraceptives, what we're actually doing is suppressing the ovaries to prevent pregnancy. So we do see an AMH that's about 25% lower on oral contraceptives, but that reverses when people stop. So if you do a test for AMH on someone who's on birth control, it's a very reasonable test, and you just know that it's going to be suppressed by about 25% of when they come off. So if you get a test result that comes back an AMH of 12, then you know that off birth control is going to be about 15. It's easy to correct for, and being on the pill is no reason not to test your AMH if you have any concerns or are interested in knowing what your AMH is. The sauna histogram is another common test, and I have several pictures from patients we've seen here. So the sauna histogram, it kind of is like a pap test. We use a tiny little catheter and place it inside the cervix. So that part really just feels like having a pap done. Then the speculum comes out, and we put a little saline, so it's an IV fluid, into the uterus. That opens the uterus up and can show if there's anything in the uterus which could affect implantation. So polyps, that's the first picture. Polyps are like little skin tags. They can grow in the uterus. Sometimes they can cause funny spotting, but oftentimes you have no idea they're there. You have no symptoms at all. They're benign, so we're not worried about them from a long-term health perspective. But if you have several polyps or a big one, they make it harder for implantation to occur. So it can be good to know that this is there ahead of time. It's a fairly simple procedure to take them out, and then you've improved your chances of fertility, of getting pregnant. Similarly with fibroids, you can see the second picture. That's a nice, beautiful fibroid that's inconveniently growing right in the uterus. So this individual actually did become pregnant but had an early miscarriage, and we were worried that perhaps this fibroid was in the way of the developing pregnancy. So she then had that fibroid taken out and is now on her second pregnancy. She's a lovely patient. So the last one is a septum. So that's when the uterus has that big dip in the middle. Again, if it's a small dip, it's normal, but if it's a larger dip measuring more than a centimeter, it makes it harder for implantation to occur. So your body really does want the uterus optimized to have conception occur. I didn't show a picture of how we check the tubes. It's on a histogram because it's an action shot, which is harder to take. And what we're looking for at the time of this test is, do we see the saline flow through your tubes? And if we see it flow through your tubes, then they have to be open. So it's our way of confirming that tubes are open. With cycle monitoring, so this is a process where you come in several times. So the first time you come in is when you have your period on day 3, and we do blood work and ultrasound. And that's a way for us to get a baseline check of your hormonal profile and your baseline antral follicle count, that resting follicle count. We then take some days off, usually about a week, and then we bring you back leading up to ovulation for the daily monitoring. So what we're really looking for there is to see what hormone levels you have at the time of ovulation. Do you develop a nice big follicle? So one of those antral follicles should grow. Are we seeing that? And is the lining of the uterus getting thicker for implantation to occur? So usually people come in 3 to 5 days in a row during that time. So it is a busy time, but it's our way of really seeing, is ovulation happening normally? For people trying to get pregnant, we tell them, this is when you're most fertile, so they can try to get pregnant at that time. A week later, we do a progesterone test because we know progesterone peaks a week after ovulation to see if that hormone's in a normal range. And then if you did try to get pregnant a week after the progesterone test, we do a pregnancy test to see if you got pregnant. So that's cycle monitoring. It is a busy time. The semen analysis. So this picture is taken from the American Society of Reproductive Medicine, but it looks at several things in the semen. So it looks at the volume, so how much fluid is produced. It looks like the total number of sperm, the concentration of sperm, so the number per milliliter, and the percentage that are swimming, and the shape of the sperm, the morphology. So do they have a normal shaped head and a normal shaped tail? Women tend to make 1 egg per month. So I feel like women go for quality. They make 1 egg per month. If we're lucky, it's a healthy egg for a healthy baby. Men make millions of sperm. It's not uncommon to see a count of sperm that's between like 40 and 100 million per month. So they go for quality to achieve a pregnancy, or quantity, my apologies. So common procedures. So for couples who we see, we often take about 4 to 6 weeks, so about one cycle, to get the testing organized for both men and for women, and to monitor a cycle. And then we meet and review all the results. And depending on the results, we may recommend different things to help optimize getting pregnant. So we can do ovulation induction, where if somebody isn't ovulating quite normally, where we give medication to produce ovulation. Ovarian stimulation, so if everything looks normal, but we're worried perhaps due to a woman's age, that maybe it's an egg quality issue, we may stimulate the ovaries to make more than 1 egg to try to increase the chances. Intrauterine insemination is when at the time of ovulation, the sperm gets washed. So they wash away the ones that aren't swimming, and we put the best sperm directly into the uterus. So there's a couple studies which go back to the 1960s, which showed that for women with cystic fibrosis, IUI significantly increases pregnancy rates because by putting the sperm in the uterus, we've also now bypassed any thick cervical mucus which may be there. So oftentimes for women with CF, this is our first step, is to say, okay, well, we know this may be an issue. Let's put the sperm directly in and see if putting them past that cervical mucus is enough. When needed, we do in vitro fertilization. So for men who do not have that vas deferens, so the sperm are being made in the testicles but are not being ejaculated, we do in vitro fertilization. So those sperm will get extracted from the testicles, but because when you're extracting them, you get sperm at a whole variety of maturity levels, you usually don't get a count high enough for IUI. So those sperm actually are most likely to lead to pregnancy when it's done in the context of IVF, so in vitro fertilization. And that's, I'll explain that in a little bit more detail. We may refer people for surgery if surgery is felt to be needed, particularly if there's a polyp or a fibroid in the uterus. And we also do elective egg freezing, which has gotten much better, particularly over the past 5 to 10 years. So for people who do have a declining AMH, but the timing isn't right, we can do egg freezing to give them some extra time. Ovulation induction, so that's medication to produce an egg more predictably if you're not ovulating, and stimulation is to produce more than one egg. Now, one thing I really do want to mention is that if we stimulate the ovaries and you make more than one egg, there is a risk of multiples, which really has to be taken very seriously because that's a much higher risk pregnancy for anybody, particularly for women with cystic fibrosis. IUI, so this is when the sperm is washed and then it's prepared, and this is how it's prepared. It's prepared in this a nice little vial, so it's prepared and then drawn up and put directly into the uterus. IVF, so IVF is, it takes place in a very specialized lab, and this is actually what it looks like when the sperm is injected into the egg. So in IVF, we usually have a goal of producing 10 to 15 eggs, which will then be retrieved. So that's a small procedure. People are awake for egg retrieval, but they are given medications for pain and to help relax them. Those eggs then go to the lab to get fertilized with the sperm and then grown for 5 days or really up to 7 stages till you get to a mature blastocyst. So not all eggs, the reason we want to start with about 15 is not all eggs will be mature, they won't all fertilize, and they won't all become blastocysts. Of the blastocysts, depending on your age, that's a good predictor of what number will be chromosomally normal. So we want to start with a lot of eggs to really increase the chances of having 2 or 3 that are chromosomally normal, and at that point they have a 70% chance of being a healthy ongoing pregnancy, which is actually quite a high level. Fertility, we do recognize that fertility is a really emotionally charged time. I think people are pretty aware of fertility right now, which is great. It's gotten more attention in the media. People are planning their pregnancies better than before. But when you're ready to get pregnant, you're ready to get pregnant now. Pregnancy rates change with age. So even for when women are at their most fertile, we only see pregnancy rates of about 25% per month, which if you think about it, it's a 1 in 4 chance. It's actually not that high. It's like a batting statistic, right? Like it's really most times you're going to strike out. But when you're going through that and you're trying and then you're waiting to see if you're pregnant and then you're not and you're trying in the next month, time can really feel very heavy. So clinics do know this, and staff are really trained to be supportive. If they're not, then you should absolutely feed that back to them. And sometimes that's not enough. Sometimes things are hard and you're trying to balance your desire to have a family with other goals and things going on in your life. And certainly there are other resources that are available, and they can vary a bit clinic to clinic, but it's never a bad idea to reach out. I also want to mention that there is an upcoming webinar focused on emotional coping, so that will give you more specific information. So that's really what I wanted to touch on. in summary, people with cystic fibrosis absolutely can and do have children. I think it's reasonable to be referred to a fertility assessment early. Not all primary care providers have been trained to consider the impact of cystic fibrosis on fertility. So educating your care providers and requesting an early referral, people should be respectful of that. Common tests can include blood work, semen analysis, ultrasounds, and treatment can include everything from just helping you time intercourse to ovulation induction, insemination, or IVF. An emotional support can be helpful, so if you need it, do please reach out. So that's what I had, Megan. That's what I want to share with everybody. I don't know if there are any questions or anything else that wants to be brought back to me. I did want to save time for questions because people often do have a lot on this topic.
We'll just wait and see if any questions come in. Otherwise, we have a few questions from before when people registered. If now is a good time for me to read those for you, Carrie.
Oh, sure. Yeah.
Okay. So one of the questions was what potential impact the fertility medications may have on a woman with CF and or CF-related diabetes.
Yeah, absolutely. That's a really good question. So the medications used in fertility, so ovulation induction medications, should have very minimal effect on either because they're really working within the normal physiologic environment of that person, right? So estrogen levels don't change too dramatically from their baseline. In IVF, though, it is quite different. So during an average cycle, if a woman has a peak estrogen of about 1,000, in IVF she makes 15 eggs, she could have a peak estrogen of around 15,000. So that's significantly elevated from normal. Estrogen can have an effect on lung function. So I really think it's important to keep that in mind, and that if a woman is undergoing IVF, it's important that she talk to her fertility physicians as well, to let them know that that's her plan, and she can work with them to say, maybe we should run a lower stimulation protocol, or should we run things differently based on her current health status and risk. Many women have gone ahead with IVF and done so quite successfully, but it is a higher risk time because of not the medication itself, but because of what the medications are producing within the individual, estrogen primarily. The CF-related diabetes, that's actually less risk with the medications we use, but it is important to run our medications by your pharmacist to make sure that there are no interactions and that nothing we should really be aware of ahead of time. Medications can vary person to person, so that's why I'm being a little bit vague, but it is important to keep the teams in really close communication regarding all the medication interactions and dosing.
Perfect. Thank you. So another question that came in is, what happens if I have an exacerbation in the middle of an IVF cycle?
And that can happen. Ideally, it would not, but if it does, then I think it's really important to notify both the fertility specialist and your team early. So at the first suspicion that you may be developing an exacerbation, the fertility specialists aren't trained to manage your exacerbation, but they do want to know, because should they adjust their medications or should they adjust any plans or timing within that? And then it would be your cystic fibrosis team that would really be in charge of managing it. But it's important to let both teams know right away and early, and hopefully by doing so they can collaborate together to, obviously we need to optimize your health and the exacerbation, and also hopefully be able to maintain the fertility treatment plan to go ahead, especially if it's an IVF cycle. There's a lot of time and energy and money invested, so to try to get through it if possible. And things can be adjusted during an IVF cycle sometimes to trigger early, decrease the dose of medication, to do things to modify it to really optimize the health of the person.
Perfect. Do you have any comments on any supports that might be available to help cover the cost of these treatments?
So it varies a lot province to province. At this time, I believe only Ontario, where I'm located, currently has funding for in vitro fertilization. But the way it's set up in Ontario is if you have a valid OHIP card and are under the age of 43, and you are eligible for one cycle of IVF, which is great. The government has allocated funding on a yearly basis based on their fiscal year, and it's a finite amount of funding, which is then distributed to different fertility clinics. So it's not that you can just say, oh, I want to do it now and start immediately. All the clinics do have some degree of a wait list for funding, but that funding does exist. So this is something that you've been thinking of and you're a bit concerned about the finances and you're in Ontario, then certainly seeing a clinic and getting on their wait list can be valuable. The other provinces, as far as I'm aware right now, do not have funding for IVF, but oftentimes private insurers do have some fertility funding. So your private insurer may cover some of the medications, may recover some of the procedures. I've seen a few plans which say you can spend up to a certain amount on any fertility treatment you want in your lifetime, which is great because then you can really use the money based on what you need and where you need to put it. The intrauterine insemination, the blood work and procedure is covered, I believe, across Canada, but again, medications often aren't covered. And sort of strangely, sperm wash is considered a medication. So keep in mind too that the sperm wash, although that's not, I don't know, it's a funny classification. It has to be classified somewhere, and it's been classified as a medication. So sperm washing often isn't covered, but the blood work and ultrasound is covered. Much of fertility is actually covered, which people don't realize. Almost all the initial tests are covered. Blood work, ultrasounds, cycle monitoring, sauna histograms. AMH isn't covered, but it's a relatively inexpensive test, anywhere from $50 to maybe $100. It's really not a very expensive test if people want to check their baseline there.
Perfect. So another question is genetics counseling part of the fertility process or management when undergoing fertility treatments?
Genetics counseling for anybody may be recommended. Fertility clinics can do genetic testing, but because we're not hospital-affiliated geneticists, oftentimes the genetic counseling we ordered isn't covered. So you'd have to pay out of pocket for more like a private genetics testing done. So if people are thinking of going through treatment and would like their partner screened for cystic fibrosis, then they could do it privately, or they could refer to a genetics clinic to have that done. And to some people, it's important to have their partner screened, and for some people, it's not gonna affect any decisions they may make, so it's less important. So certainly we do discuss genetics, but genetic counselors have very specialized training, and they do have a much broader scope and greater depth of knowledge than your average fertility physician. So we will refer to them if needed and if desired by the person, or we can order some other tests as well. But oftentimes when we order, it has to be done privately, which isn't always ideal.
Okay. I'll ask one last question, and I think you covered a lot of the kind of pre-generated questions during your talk. So the last question now is, are there any risks doing either the IUI or IVF?
So those are a bit separate. So during IUI, the risks are quite minimal, especially if it's a natural cycle. So IUI is really a placement. We're placing the sperm closer to the egg. And if you're only producing one egg that month, then the risk of multiples is no greater than the baseline risk for anybody else in the community. The sperm are closer, but putting them closer does not make them more likely to produce more than one baby. IUI feels a bit like a pap test as well, so it can be a bit uncomfortable. Sometimes the little catheter that puts the sperm inside can cause, like a little tiny scratch on the cervix. So you may get a tiny bit of spotting, but rarely. People usually do IUI. It's very quick. It's just a couple minutes, and then they get back up and go back to work or go back about their day, and they feel absolutely fine. So risks during IVF. So those are inherently more significant. Because what we're doing in IVF is we're stimulating to produce all those eggs. You're going to have a much higher estrogen, which can have an effect on lung function. For people who have a high ovarian reserve, there is something called ovarian hyperstimulation syndrome, and we use medications to reduce that risk, and we monitor for it very, very carefully. But it does exist. It rarely happens, but it can happen, so that's greater risk. When we do IVF now, what we used to do is, because embryo freezing, it worked, but it wasn't, you lost, so the embryos, the freezing thawing process, some embryos wouldn't survive either the freeze or the thaw. What we used to do is transfer an embryo right after, that 5 days after the egg retrieval, and then just freeze any additional ones. Because freezing and thawing has gotten much, much better, what we usually do is let you go through the IVF process, let you return to normal. So have a period, go back into a normal cycle with a normal level of estrogen, and then we do an embryo transfer. By doing that, pregnancy rates are actually higher, and the pregnancies are healthier pregnancies because the embryo is going into a much more physiologic environment than it did when your estrogen was like 15,000 times its baseline. By doing it that way too, we can also screen embryos ahead of time, so we can put back a chromosomally normal embryo, which has a higher probability of pregnancy and a lower risk of miscarriage simply by being chromosomally normal. For some people with cystic fibrosis, if their partner is also a carrier, they may want to screen embryos that would not have cystic fibrosis if they choose. And if they choose that, then we can also use IVF as a means to do that for them. In IVF, especially for someone with cystic fibrosis, where a multiple pregnancy would be a greater stress on the body, we do single embryo transfers, which really controls the risk of multiples. Historically, we would say, well, we can't test the embryos. We think that there's a risk that maybe a few of them will be chromosomally abnormal, so let's transfer 2 in hopes that at least one of them is chromosomally normal. The risk then is, of course, what if they're both normal and healthy, and you have a multiple pregnancy. When we do medicated cycles with IUI is when we're really playing with things a little more dangerously, because we give you medication, you make more than one egg, and then we put the sperm there. Well, now there is a chance that both eggs could be healthy and fertilize and lead to a multiple pregnancy. So that would be where I'd really want caution for people with cystic fibrosis to say, really, I think it'd be safest to do natural cycles with insemination or ovulation induction if a person is not making an egg on their own, but really try to get just a single egg, or do IVF to start pushing things to make multiple eggs is when we're really starting to gamble with multiples, which isn't safe.
Great. Well, thank you so much, Dr. Schramm. We're going to shift gears, and we're going to go into the next part of our webinar. We're going to have 2 adults with CF share their experiences going through fertility treatments. So I'm going to share my story first. So I know that I've already introduced myself briefly, but just a little bit more about me before I get started. So let me just make sure. There we go. So I'm 33. I live in Calgary, Alberta, with my husband and our 2 sons. I'm part-time educational therapist, and I also stay at home part-time with. So my husband and I met in 2006, and we were married in 2008. We always knew to start a family one day together. After we got married, my husband came to CF clinic with me and was tested to see whether or not he was a carrier for CF. Thankfully, his carrier testing came back negative, and because my health was good, my CF team gave us their approval to trying to get pregnant. We started trying for a family in the fall of 2010, just after I graduated with a master's degree in occupational therapy. Every month that went by, I would be hopeful, and each month I'd be disappointed when it didn't work. As time went on, I became more and more frustrated and upset when the disappointment would set in that it hadn't worked yet. After about 9 months of trying unsuccessfully to get pregnant, my husband and I started talking to our doctors about infertility. We were both sent for a lot of tests to see whether there were any medical explanations as to why I was unable to get pregnant. We were finally referred to the Calgary Regional Fertility Clinic, and in the fall of 2011, we met with the team, reviewed our test results, and were finally and officially diagnosed with unexplained infertility. Essentially, this meant that all of our tests came back normal, and nothing that they could test for was able to offer an explanation as to why we weren't able to get pregnant. In early 2012, we finally got to start going through fertility treatments. After discussion with the fertility clinic and my CF clinic, we opted to try intrauterine insemination, combined with me taking the fertility medication Clomid. We ultimately ended up going through 6 cycles of IVF, and I took a little bit of a break, number 3 and 4, to give my body a break from the Clomid. None of these IUIs worked. After 6 failed IUIs and going off the recommendation of our fertility clinic, we opted to switch to in-vitro fertilization. Additionally, because we had unexplained infertility, we opted to not take any chances and went ahead with ICSI to fertilize my eggs. Fortunately, our fertility clinic did not have an incredibly long wait list for IVF, and we were able to start our cycle after only a few months of our last failed IUI. In the fall of 2012, I began to start taking the medication to begin our IVF cycle. I had regular appointments at the fertility clinic to monitor blood work and how my eggs were developing. With my blood work values and the excessive amount of eggs that I ended up producing, I was borderline for hyperstimulation, and there was a lot of talk with the fertility clinic about whether we would be able to go ahead with the fresh embryo transfer or whether my body would need a break before transferring the embryo. Ultimately, I ended up having 28 eggs harvested, 19 of which were fertilized using ICSI, 19 of which ended up surviving to become day 5 embryos. We were able to go ahead with the fresh embryo transfer and began the incredibly painful 2-week wait where it's impossible to know whether the embryo transfer worked or not. Unfortunately, I did not end up becoming pregnant that cycle. We were completely and utterly devastated, and it was certainly the hardest time in our infertility journey. I think we were both incredibly near our emotional breaking point when we decided to try again using one of our frozen embryos. So on February 6, 2013, one single embryo was transferred. After another painfully long 2 weeks, I received the call from the nurse from the fertility clinic. I was at work when the call came through. Although I somehow still retained some hope that it might have worked this time, I was ready for more disappointment. However, this time I heard the nurse say the word pregnant. I'm pretty sure my heart stopped. I definitely cried for a couple of minutes before the nurse could continue with our conversation. She told me that my due date would be October 26, 2013. I scribbled that date on a piece of ripped up paper towel that I was able to find and carried it around with me that entire day. March 11th was another one of those life-changing days that I'll never forget. It was my first ultrasound. My husband took the morning off work to join me, and we were so incredibly nervous and anxious to find out that everything was okay with the pregnancy and that we would be able to see a heartbeat on the monitor. Not only did we see one incredibly strong heartbeat, but we saw 2 incredibly strong heartbeats. And it turns out that ultrasound techs are not allowed to joke about that kind of thing. Trust me, we asked. All of a sudden, we were expecting twins, identical twins. Our single embryo that we had transferred had split into 2 little developing babies. Later, we found out that those 2 little babies would be 2 little boys. My pregnancy was actually incredibly and remarkably smooth, despite being extremely high risk between my CF-related diabetes, and the fact that I was carrying monodi twins, which means that the babies shared a placenta while they each had their own amniotic sac. I had 0 complications or problems the entire pregnancy, which I later found out was almost unheard of because of the type of twins I was carrying. I did, however, become very acquainted with my CF team, my diabetes and pregnancy team, and my high-risk obstetrician, all of whom I met with very, very regularly. I was getting ultrasounds monthly, which then switched to biweekly, just to ensure that both twins were growing properly. I was able to gain 45 pounds, and I maintained my lung function throughout the entire pregnancy. I was able to work full-time up until 28 weeks, at which point I went on short-term disability for the remainder of my pregnancy. At 36 weeks and 2 days along, I was checked into the hospital to give birth. I was induced the night of September 29th and delivered my sons the morning of September 30th, only 9 minutes apart. Desmond James was born at 8:59 in the morning, weighing 5 pounds 7 ounces, and Charlie Cohen was born at 9:08 a.m., weighing 5 pounds 11 ounces. Words could never describe how incredible it felt the first time I got to hold them and look into their faces. They instantly changed my life in the most beautiful way. It was an incredibly difficult and lengthy journey to become a mother. I had almost given up on the idea that it would happen. Despite the struggle, in retrospect, I can say that my experiences helped me grow as a person. My husband and I were fortunate to have grown closer together, although infertility can all too easily tip relationships the opposite way. I became a more patient and empathetic person, both qualities that I feel are valuable as a mother. Lastly, I learned how to cope with very difficult and ugly emotions and come out on the other side as a better person. So to those that are listening that are currently experiencing infertility, please know that you're not alone. While infertility is not often talked about, it's actually extremely common, and it can be an incredibly painful, emotional journey. So make sure that you're kind to yourself with your struggles. My best advice would be to not try to bear it alone. Find somebody that you can confide in, whether that's a family member, a close friend, or a healthcare provider through your fertility clinic. So next, I'd like to introduce Bob Cascanet. So Bob is 36 years old and was diagnosed with CF at around 3 months of age. He's married to his lovely wife, Dana, and they have one son, Tyler, who is now almost 3.5 years old and was conceived using IVF. He currently works as an engineering consultant and lives in the Hawkesville area just outside Waterloo, Ontario. So Bob, I'll turn it over to you now.
Thank you very much, Megan. So yeah, as she said, I'm from the Hawkesville, Ontario area. I met my now wife back in 2011, and we were married in 2014. Most of my life, I didn't really think it was possible to have kids. Growing up as a male, I'm a double delta F508, which means that I don't have a full vas deferens that formed. So I wasn't really sure if kids were ever going to be an option for me. So I started out speaking with my CF team about the possibility of having kids in my late 20s, and ended up being referred to go see a CF specialist, urologist in Toronto by the name of Dr. Jarvie. So when I saw Dr. Jarvie, it was more of a physical examination, examining the testicles and going through a full health background, medications, health history, just the usual thing that you would expect. It was around that time, so there was no semen analysis involved at that time, but just based on the physical examination, he said, yeah, everything looks good, should be a good candidate for IVF. I did ask him if IUI would be an option, and he said because the vas deferens isn't fully developed, and just based on how males are with CF, that typically the sperm wouldn't be mature enough or strong enough for IUI, and they typically recommend that you go straight to IVF is really the only option for people in that situation, I suppose. Now, other urologists may or may not have a different opinion, but Dr. Jarvie is a very well-respected one, and I think that it's probably the place that most males with CF that would be similar to me should go straight to without attempting any of the other options. So that was good news. I was obviously elated to hear that. I really wasn't expecting that. I wasn't really sure if it was going to be good news or bad news, but obviously I was thrilled to receive that news. Shortly after that, we began on our journey after getting married of attempting to do IVF. So we contacted actually Hannum, which I believe the doctor that was presenting also was from. So we did Hannum Fertility Clinic in Toronto, and we started that in 2014. So from the male perspective, how that works is typically, so part of the screening process from the urologist, they want to know medications, things that you're on, because there's a lot of stuff that you might not be able to take leading up to them having to extract the sperm. So I was taking one medication that was a testosterone inhibitor of some kind. So they basically said I had to get off that 6 months in advance. It shouldn't really affect you for any CF medications you're on. Any of your inhaled treatments, things of that nature should be totally fine as far as I'm aware. But it's good to identify that early on, because they need to get you off of certain things if you are on certain things many months before you actually get to the stage of going through IVF. Excuse me. So there's about a 6 month delay or so, and then we started the admission and the registration at the IVF clinic in Toronto. So from there's a lot of very in-depth health questionnaires for myself and my wife that you have to go through, and they need to evaluate certain risks or any risk factors or any other underlying issues perhaps, and you do blood work and you do a series of other tests and examinations, lots of meetings, lots of information sessions, and lots of reading and lots of consents that you have to sign, and it's a lot of paperwork, which you would expect. And then we actually started the process. So for how it worked is, we did the usual the usual work for my wife, where we got into the transfer stage and had to do all the hormone treatments and injections and so forth. And then on the day that they were doing the extraction of the eggs, that was when I also attended, and they did the extraction of the sperm. So because the vas deferens isn't formed, the only way to get the healthy, viable sperm out is by actually going in and extracting it. So at the facility, a urologist attended, and I went into a room, and they basically, they freeze the area of the testicles, and then they do an extraction, and they can actually pass the sample straight to the lab while you're laying there, and then they can actually do an analysis to make sure that the extraction of the sperm that they made was good, and that the sperm is viable and good to go. Now, it did take a few times. They had to do 5, 6, maybe 7 attempts of taking sperm out before they found the optimal sperm sample, I suppose. So it's a little nerve-wracking laying there and not really knowing, oh man, you've been told verbally that everything's okay, but are they actually going to find any issues while you're doing that? So luckily, after some waiting, they were able to find the sperm that they needed, and all was well. So they did the combination of the eggs and the sperm, and we ended up getting 5 healthy day 5 embryos out of it. So we did our first transfer shortly after that. It was back in just the end of 2014. So we transferred 2. Looking back on it, we probably should have just done the 1, but we transferred the 2, just not really knowing what we were doing, and just kind of hoping for the best and thinking 2 is better than 1, and let's really increase our odds to the most optimal that we could. So as Megan was mentioning, that's a very painstaking 9 days, approximately 2 weeks that you have to wait for the pregnancy test and then the results. We got a call, and we got some very good news that Dana was pregnant, which was amazing. Unfortunately, it turned out to be a non-viable pregnancy through the testing that was done in the days after that, and we had to Dana had to take a medication to basically induce induce a menstrual cycle and basically clear everything out, as the pregnancy wasn't going to work. So that was a very emotionally difficult time for us, to put it mildly. We decided to take a little bit of a break, took a couple months, and we went away, took a vacation, just tried to relax and get our mind on other things. Then we came back and we did a second cycle, and we ended up being successful. So that was a frozen embryo transfer, and we ended up being successful again in getting pregnant, and that led to a healthy pregnancy. My wife had no issues. Got up to full term, and actually our little guy was a little bit lazy. I don't think he wanted to come out. So 10 days after the due date, they said, okay, it's time to induce. We're at the time where it's time to get the baby out. So they induced a pregnancy 10 days after our due date in November. And funny enough, our due date was November 13th, which was Friday the 13th. So we're not very superstitious, luckily, so we didn't look at it as a big deal, but thought that was kind of funny. So on November 23rd, 10 days later, my wife was induced, and it was a very long labor, but he was a healthy delivery. He did have a few minor issues at birth, which are pretty typical, nothing to do with CF, nothing to do with anything like that, which have all since been dealt with, and he's a very, very healthy 3.5-year-old boy, and we're very blessed to have him. So with that, we said, well, we still have 2 embryos left, so what do you think about trying for another? So we did try 2 more times, and both times led to pregnancies. And unfortunately, both of those pregnancies turned out to be not viable. One was actually pretty far along. It was several weeks along, and it ended up not working out, unfortunately. So we did decide to stop our family after just the one child and the one full cycle. We were kind of hoping for 2, but there was a series of factors that led us to not wanting to do another cycle. I will say, after having our son, that my health was very good up until having our son. I was very stable for many years. I've been very lucky with that. One thing that a lot of people go through, CF or otherwise, is you're going to be very run down in the months after having a baby. You're just not sleeping right. You're very, stressed out, really overdoing and exerting yourself in ways that you probably never have before, while being very exhausted at the same time. So I'd suggest anybody undertaking this, male or female, set up as many resources and things that can help along the way as you can, as early as you can. I have since stabilized and everything's been good now, but that first 6 months to a year was a little rocky. That was one of the other reasons that we decided, maybe I'm not sure if we want to do this now. My wife and I were both around 30 when we started this originally and had our son, and now I'm in my mid-30s now, and my wife is a year and a half younger than me. So we certainly could still have another child, but we just figured that it's probably best that we just be happy with the one that we have. So I'm not sure if I addressed everything adequately for everybody, but I'm certainly open to any questions that anybody has.
Thank you so much for the story, Bob. I really appreciate you taking the time to do that with us.
No problem.
So I'm going to let, we have a few minutes left for questions here. So if you do have any questions, please submit them into the chat box of the WebEx. We did have a question come in earlier, just about with men with CF and reproductive issues, and I'm just going to plug for our first webinar that was hosted a couple of months ago, where we did an overview of the male and female fertility issues with CF, and that webinar was recorded and is available online. So please look for that, and Dr. Liz Tolis did a fantastic going over fertility issues with men with CF. We'll just sit here and make sure that there's no other questions that anybody has. Carrie, were there any last thoughts that you had before we wrap things up here?
Yeah, thank you, Megan. No, I really want to thank you and Bob for sharing your stories. You guys have done a very excellent job, as well as a very honest representation of what it's really like. People always talk about, the baby and how wonderful that is, but it often isn't straightforward, and it can be a challenging journey along the way. I think unexplained infertility is particularly hard because there's no good reason, and we all want a reason for things. And certainly, I think with people with cystic fibrosis, with patients I've worked with, they always turn back and say, well, it's just because of my cystic fibrosis. And sometimes it isn't. It's just other things can happen as well, just like they can to anybody else. So, no, you guys have done a wonderful job telling your stories. And I think stories and talking to other people, whether they've gone through similar things or have cystic fibrosis, can be really valuable for anybody because there's a lot of parallels.
All right. Well, thank you so much, everybody, for joining us. Thank you especially to Dr. Schramm for taking the time to join us to speak on fertility and family planning for people living with cystic fibrosis. Thanks again to Bob for sharing your story. And again, thanks for everybody for tuning in. So our next webinar on fertility treatment options Part 2 is going to be hosted sometime in June. So please keep an eye out for that specific date once we have nailed it down. Any questions can be directed to advocacy@cysticfibrosis.ca. And this webinar was recorded, and it will be made available online for future viewing. So thank you to all.